Welcome to Hope for Med.
Hope for Med.
Hi, everyone. Welcome back to the Hope for Med podcast. I am your host, Dr. JB, and today's featured guest is Dr. Nicholas Fogelson. He is a surgeon in private practice in Portland, Oregon, and focuses on pelvic pain and endometriosis. Welcome to the show, Dr. Fogelson.
Thank you, Dr. JB. Thanks for inviting me, and we look forward to talking to you.
So let us start from the beginning. Can you share with my audience your origin story?
Well, I grew up my origin is Oregon. So I grew up in Portland, Oregon, or I grew up in Eugene, Oregon, actually, where the home of the Oregon Ducks, right? Where when I was a kid, they were a terrible football team, and somehow they've become like a good team over that period. Nike money. But anyway, so I went to college in Eugene, Oregon, and then eventually really wanted to be a physician from a very young age. And my mother said I wanted to be a physician when I was a sperm. And I literally from a very young age, I always wanted to be a doctor, and eventually went to medical school actually in Oregon as well. And became enamored with, at that time, obstetrics and also surgery, but ended up deciding to do a residency in OBGYN and had a great time, really enjoyed that work. I was very passionate about it. I mean, at one point I was profoundly passionate about it and kind of had a career in academia for a while where I did a residency, and then I did a academic stint at the University of Hawaii, actually, and then ended up moving back to South Carolina. I was married at that time, and for reasons of my marriage, I ended up actually going to Hawaii because my wife matched there for her residency. Mm-hmm. And then wanted to come back to South Carolina, where I had been a resident. So I was a resident in Charleston, South Carolina, Medical University of South Carolina. And then wanted to come back to South Carolina because she wanted to do a fellowship there. And so we came back there. And then I was on faculty at a couple of other places, University of South Carolina. And then actually we ended up getting divorced. That relationship didn't work out. And I did a fellowship at Emory University, and then continued in academia there. And then for various reasons that we could certainly be apropos to talk about, eventually decided to stop being an academic and focus on private practice. And now I have a very focused private practice in pelvic pain and endometriosis, the bane of every gynecologist, that the vast majority of gynecologists are like, I don't want to see those patients. That's all I do. And what's funny is that some people say like, oh my God, if I had to see pelvic pain patients every day, I'd shoot myself. And I'm like, my God, that's the only thing I want to do. It's fantastic. And so the question is like, how I got there, I guess, because now I have a practice that's for the first time in like the last 3 or 4 years, is the first time in a long time that I really enjoyed being a physician. And I am adequately rewarded. I have time for my family. I have not only that, but I have the time for professional development that I never had in academia to really pursue what I want to do. And so if I had one message to give the listeners is that if you're a really smart, intelligent physician, don't let anybody convince you that private practice is a waste, and that you're too smart to not be in academia is the most stupid thing anyone's ever said. It's like, I cringe. I was told that so many times, and I was like, Dad, don't believe it. Private practice is a noble and fulfilling pursuit done correctly.
Well, a couple things. You are your story, how do I say this? Deciding to become a doctor from when you were a sperm is the earliest time that I've ever, heard somebody say that they decided on becoming a physician. This was predestined. Like, so were you born into a family of physicians?
No, my mother was a clinical psychologist. My father was an entrepreneur. I literally don't ever remember. I mean, I had like a brief dalliance with wanting to be an astronaut.
Yeah.
And I have a fantasy of wanting to play golf on the PGA Tour. And I took a brief, I was a decent golfer. I took a brief detour and actually took a year off of medicine to try to play golf professionally, which was actually an interesting thing. It was an interesting thing I did, but that didn't work because I wasn't good enough. But I found out, which was why the year was worthwhile. Mm-hmm. But yeah, I mean, I like, other than a couple of little brief detours, like it never occurred to me that I would ever want to be anything else. And And when I got to medical school, I was profoundly sure that it was right. I was on fire. Like I absolutely just was in ecstasy of joy and fascination in what we were doing. And, but they say that in order to burn out, you have to be on fire. And that like people that have a middling existence in their career are far more likely to enjoy it at a middling level forever. Whereas the person that absolutely is profoundly in love with what they do is the one that is going to become disillusioned and fall out of it more likely. I think that's true. Like I've had people tell me that. I'm like, yeah, I think that's true. I see people who have kind of a reasonable, it's funny, you're an ER physician. Like it seems to me that ER physicians are pretty happy people. Like they have kind of like a middle existence in medicine, because every ER doc I know, if I ask them to describe what is their core, the core of who they are, they'll tell me they're a drummer, or they're a skier, or they're a rock climber, or they're a parent. I don't ever hear them tell me their core existence is being an ER doc. Whereas most surgeons, if you ask a surgeon what's their core existence, and they say, oh, I'm a surgeon. And so I think that to some extent, like certain paths in medicine are very lend themselves towards seeing medicine as being your job, and other paths in medicine lend themselves toward your medicine being your core identity. And I think if you choose the path that requires medicine to be your core identity, you're going to have moments of disillusionment and moments of crisis where you go, well, who the hell am I if I'm not a doctor? I was profoundly impacted by the song from Encanto. Have you seen Encanto?
Yes, I did.
Surface Pressure, where the character Luisa has tremendous powers. She's super strong. And yet the pressure of lifting heavy rocks her entire life is profound, even though they're not heavy for her. And that being given a lot of power and the responsibility that comes with that, of course, the corollary is even Spider-Man, that with great power comes great responsibility. But like once you have a lot of ability, the expectation of society that you use those abilities for external benefit, not your own benefit, from the benefit of society, it becomes a tremendous pressure that over time can be quite overwhelming. And in medicine, in what I do, like I have focused myself more and more and more into remember how I mentioned that I do stuff that no one else wants to do? It's like the reason why no one else wants to do it affects me too. And like I've focused my life in things that are very, very difficult, perhaps for my own psychological desire to be iconoclastic and different or something, and to conquer the things that other people don't want to deal with. And yet at the same time, there's a tremendous pressure. Like once you become good at doing something like that you better do it because no one else wants to do it. And so if you don't do it, then now you're letting the world down. And so that is, it is in my own path became a difficult time in the middle of my life, kind of when I was in academia, to some extent, becoming very good at something, but feeling this tremendous pressure to provide that for the world. And then not being able to do it on the terms that I felt was acceptable. And that led to a sense of burnout, of where one is, I'm trying to take care of patients that no one else wants to take care of. Because when the patient with pelvic pain comes in and says, oh, I've got this pain, you know that you have 15 or 30 minutes to talk to them. And you're like, this is going to take hours to sort out. And even then I may not fix it. So then you feel like, oh my God, just get out of my office here. I can't deal with this. And yet that was the environment I was in. Like I was trying to take care of those kinds of patients. And I wanted to take care of them. I felt a personal desire to try to help them. And the occasions where we really did help them, it was very gratifying to really help someone that other people hadn't been able to help. And yet the structural mechanics of academic medicine was such that no one was giving me the time to properly do it. And I think throughout medicine, I think that a lot of physicians who believe that they have fallen out of love with medicine, it's not medicine they fell in love with, it's the way that they're doing medicine. It's the way that the medical system is forcing them to do what they do. And so if you're trying to do something really complicated and they only give you 20 minutes to do it, it's just like, forget it. The patient's unhappy, the doctor's unhappy. You probably don't fix the patient. patient feels like they're not being listened to, and then they go out online and write a complaint about you, the doctor doesn't listen to me. And I'm like, yeah, I tried, but I don't have time. But they don't understand the other side of that, of course. Not that they should, but the reality is that the system has not structurally given you the time. And I really, you feel for the patient that has something that's hard to figure out, because patients, by and large, medicine want the sort of the systematic industrial way of practicing medicine doesn't really give time to really think about things. Like, you better know what to do immediately, because no one's giving you time to go and read a book or even just sit at a chair and think about it and have a little Einsteinian thought experiment about someone's condition, about, can you really figure it out? There's no time for that. And by the time, if you choose to do it at home, you're ignoring your family. If you choose to do it at work, there's no time at work. So some people have solved that by not having families. I know some people who are really talented physicians that basically don't have families. Like, they're like warrior monks who basically have allowed medicine to eat their life, and they've decided that that's the way that they're going to solve this problem. And at some level of satisfaction, I think, and also some level of sorrow over it. And everyone admires those people to some extent, like they're like the Gandhi of medicine. But I think internally they're not as happy as they may appear to be. Mm-hmm. And so if you don't want to do that, you either have to just give in to the mediocrity of what medicine demands of you, which is that, yeah, you could be a really good doctor, but the system's not going to give you time. And that's where the burnout comes in. And you say, okay, I'm either going to give in to this and kind of become a drone and just do it in order to keep your sanity, mm-hmm. and just do the best you can, and realize that sometimes it's best isn't good enough, but the system's not letting you, or you just go crazy. If you don't give into it, then you just lose it. I guess it depends on the personality of the person you are. But for me, like that sense of like, man, I could do this job so much better if the system was structured in a different way. And so eventually I just lost my desire to continue to do that. And also kind of an interesting dichotomy in academic medicine between, like, what is our role in teaching young physicians to be better doctors, and what is our role in actually taking care of our patients? Because academia has really pushed to where academicians basically have to be in private practice now. Like, you're expected to make the money and produce your salary. You're not like getting paid to teach. You better be a doctor and bring in the money that pays your salary, in addition to some massive tax to the dean of the med school and all this kind of stuff. And yet then you're expected to teach young physicians how to be doctors at the same time. And it's a tremendous like dichotomy of goals, particularly when you're trying to do things that are really difficult. The kind of things I do in pelvic pain and endometriosis are technically very, very difficult surgeries. Like, they are way above the head of some second or third year resident. And so at that time in academia, like, I was trying to push myself and teach myself how to do this stuff. Like, I did a fellowship in cancer surgery, but no one ever taught me how to do endometriosis surgery. I taught myself from YouTube, honestly. And I mean, it's kind of a joke. Like, people say, where'd you learn to do that? I say I learned it off YouTube. And
patients don't realize how much how much physicians learn and review these videos right before they go in and do these procedures for the first time.
Right. I mean, but the thing is that it's a totally new world. I mean, laparoscopic surgery, it's all recorded. And so then you can watch someone else's surgery and someone says, well, it's crazy you're learning it online. I'm like, honestly, I probably get more out of watching someone else's surgery than I would having them in the OR, like, telling me what to do. Like once you reach a certain point as a surgeon of knowing anatomy and knowing surgical technique, once you understand those things, then you just have to understand, like, what are you trying to accomplish? And if you understand that, and you can really go do it. And the first time you do it isn't really the first time. Like, you've been through all of the mechanics of how it gets done, and then you can pretty much just go do it, and you'll refine it and make it better over time. But we've moved past where you have to have a mentor physically in the room telling you how to do something. Like, you can study and learn, but that takes it. I mean, we're kind of getting off path here, but I mean, that takes a certain personality that I guess I have. I'm not sure that everyone does, of being willing to go and actually operate on someone and do something that you've kind of never done before. Mm-hmm. But having enough study of the system and enough study of like the anatomy and the technique and willing to watch videos and really kind of maybe even go operate on some cadavers. I've done cadaver surgeries before where I've literally rehearsed a surgery I was going to do. And that's a certain personality that not everybody has. But at the same time, like this is an example, like I had a surgery. The first time I ever did a pudendal nerve decompression, which is a surgery I do that like 3 people in the country know how to do, maybe more, maybe 10, I don't know, but very, very few people. And I think only 2 or 3 people in the country will do a laparoscopic pudendal nerve decompression, which I will do. Like I never in a million years would have been able to do that in academia. Somebody would have told me you're not allowed to do it. You don't know how to do that. What qualifications do you have to do that? What credentialing do you have to do that? Like none. Like whatever like official system that would be to allow me to do something that no one had done in that hospital, I never could overcome. But what that means is that in that environment, no one will ever be able to push forward and invent a new surgical procedure or push forward and do something that maybe they experimented with in Europe and they're not doing in the US. In this case, that is the case. It was impossible. Like the bureaucracy of doing creative things for patients, like the system would rather tell a patient, I'm sorry, no one can help you, than say, okay, we're going to let our doctor who's willing to try to help you with something that may or may not work, and we're going to let them try. And instead, they would say no.
Real quick, when you talk about the system, what are you talking about? Are you talking about like life in academia or what?
Yeah, I think mostly in academia because I haven't really experienced it in private practice. Like, I think the hospital mostly cares about the fact that, like, a lot of the restrictions I had on myself in academia, like, for example, let's just take this example of doing a pudendal nerve decompression surgery. If I had tried to post that surgery as an academic at Emory University, I think that somebody would have asked me would have said I don't have credentials to do that. And I wouldn't have been able to do it because they would have said, oh, you're going to need to go and you're going to need to get an IRB approval because it's an experimental procedure. We need to do this under the IRB. We need to get some lawyers together. It's just to be like, and then at a certain point, you just go, forget it. Like the inertia, the slogging would be ungodly. And then you just go, forget it. Like, I can't do it. It's too much. Whereas in private practice, the first time I ever did a laparoscopic pudendal nerve decompression, I mean, I actually practiced it on cadavers a few times, and then I went and did it. I had a patient with endometriosis. I posted it as an endometriosis surgery, and then I just moved my robot over to the side and did what I wanted to do. Nobody told me I couldn't do it. Now, maybe that's a little cavalier, but the reality is that I've developed a reputation in this country for being willing to try to do things that very few people are willing to try to do. And I have patients that fly to see me from all over the country for that reason. And that makes me feel good. Like, I have patients who today say that I changed their life for the positive, who are really, really appreciative of what I did, that I guarantee I would not have been able to do if I stayed at Emory University. I'm not talking specifically at Emory. I think Emory is a fantastic institution, and I'm not being critical of that specific institution, but like, I never would have been able to do in academia. I mean, and not to mention the fact I never would have had a surgical assistant. Like, I would have had a second-year resident assist me on something that they have no idea about the anatomy that I'm trying to deal with. Like, I have a great assistant now who studies with me and is going to do whatever I say, and I don't need to worry about teaching her. I need to worry about teaching her her job of assisting me. I don't need to worry about trying to teach her how to do the surgery because that's not her life path. And unless she decides that she wants it to be, in which case I'd support her going to medical school. But like, it's really, really hard to do difficult, complex stuff that is pushing the boundaries when you're trying to teach a second-year resident how to hold a laparoscope. It's just brutal. And again, it kind of just, at the very least, it holds you back. And at the very worst, sometimes it leads to complications in surgery. And in the end, I had some complications in surgery as an academic physician that in the end were my responsibility because I was teaching. But I didn't do them. My trainees did them, or my trainees were the direct cause of the complications. And I was the indirect cause because of being a bad teacher. And that weighs on you. It's like, and you realize, like, okay, if my pathway is to try to do this really complex, unusual stuff that no one else wants to do, I am getting burned out and I am getting really, really unhappy in trying to satisfy both of these roles at the same time, where I'm trying to teach young physicians how to do basic surgery while I do things that are extraordinarily complex. And there's no fellowship structure that would have put a fellow under me really. Like now I have a minimally invasive surgery fellow, like an AAGL fellow, which is a higher level of gynecologic surgery training that works with me. And even then that person may or may not do these things I'm doing. I may be teaching them, I may not be letting them do all the stuff that I do. So to some extent, like the structural weight of all the huge academic system was making me not able to do what I wanted to do professionally. And it was making me unhappy and not giving me the time to do what I wanted to do with my patients. It was not paying me that well. Like I felt like I was trying to do sort of extraordinary things that no one else wanted to do, but those things had no financial value. Like I was being told I was working my ass off, getting up at 5 a.m, 6 a.m, going home at 6 or 7 at night, and not even getting paid really particularly well for that. And then I had a child too. I was remarried and I had a daughter, and like in the first 6 months of my daughter's life, I was like hardly home. I mean, I was like working my ass off, and there was no end in sight. Like there was no time where I'm like, oh yeah, one day I'll be able to go to my daughter's soccer game. It's like, no, not really. I mean, like my current job is never going to allow that. And so I finally just like a coalition of things happened where I was just like, this is like intolerable. And so then I decided to leave academia. And I honestly have never, I felt like I left a cult of sorts.
A cult?
Like, I mean, that's a little strong, but like everybody in academia is so certain that the academic life is like the pinnacle of medicine. Mm-hmm. And I am so much of a better doctor now than I was when I was in academia. And
more about that. What do you mean by you're a better doctor now than when you were in academia?
I am so much more able to give the patients what they need. And I'm so much more able to give them the time. I'm able to pick up a book and go read some articles to try to help my patient, try to figure out something unusual. I'm able to pursue paths that are not in the little silo that the institution says I have to be in. And they say, you're a gynecologist. That issue with the bladder, go send it to the urologist. Or, okay, that like, so I went to study with a group in Switzerland that became certified in neuropelviology, which is like pelvic neurosurgery. That would have been really difficult to do in academia. But then the stuff I was doing, like I'm able to pursue this interesting stuff that is helping some patients that would be so hard. Like to me, that is being a good doctor, like really rekindling that passion I had for medicine and actually pursuing something that fascinates me, and then able to actually put that into action to try to help my patients. Like that was not going to happen in academia. The overhead would just be ungodly. I mean, it's not that you couldn't, but it would be like the Spartan race, like running over obstacles and under barbed wire and machine guns. And maybe at the other end, you'd do it. And then at the end, they still wouldn't pay you for it. It would just be like this ungodly, maybe they give you a medal. Maybe they call you an associate professor. What a grand reward that would be. God forbid they call you a full professor. I mean, literally like that was the brass ring. You work hard enough, we're going to make you an associate professor. Will you get paid anymore? No. Will you have more responsibilities, be required to go to more meetings? Yes, probably. It's like, and so I feel good about what I do now. Like I enjoy my work. I have time to talk to you. Would I have been able to break out an hour of my day in the middle of a Wednesday to talk to you in academia? Probably not. I mean, I do my own podcast. I do my own social media stuff. I do whatever I want to do. The point is I do whatever I want to do. Nobody's telling me what I can do. I mean, I push the limits a little bit. Occasionally people will say, hey, pull back a little bit, but not usually. And so that's made me a better doctor, and it's made me a happier doctor. Mm-hmm. Now, what's the other side of this that everybody should know? I don't take insurance. Like I got specialized enough in what I do that the insurance companies have no concept of what I do that values it at the level that I value it at, or that my patients value it at. I can't, if I do a surgery that takes 5 hours and the insurance company, if I were to code it with Blue Cross Blue Shield and they'd pay me $1,200, it's impossible. Like, I can't do it. It doesn't make enough money to pay the bills and enough money for me to, even if it paid the bills, I'd be making very little money to take home to my family that I would feel good about my job. And I was told something when I was a medical student that I will reiterate. I was told by a gentleman named Michael Wheatley, who was a plastic surgeon at the VA, who was a mentor of mine, taught me a lot of surgery. And he said, Nick, if you don't feel adequately compensated for what you do, you'll never be happy. And he's right. Like, not necessarily in a global sense. I mean, like, happiness doesn't come from money, but you will be dissatisfied if you feel like you're really underpaid for the kind of effort that you put into your job. There will always be a level of dissatisfaction there. And I don't know, like, I feel more satisfied with my job now because I do what I want to do. My patients are appreciative. I'm able to pursue what I want to pursue. And I've decided that, you know what, I think my work is worth more than what Blue Cross Blue Shield thinks it's worth. And so I'm gonna decide that I'm not going to contract with any insurance companies anymore. And I had people, like, when I left academia, I contracted with insurance companies for 3 years. But eventually, as I focused myself in all this, I developed my reputation enough, which is now international. I mean, I get calls from all over the world, that I clearly have enough demand for my services that I can support a practice without taking insurance. Eventually developed enough, demand for my services that I decided not to. And I had people tell me, Nick, you'll fail. It'll never work. Patients will never want to come see you if you don't take insurance. Just hasn't been true. Mm-hmm. All I can tell you is that it hasn't been true. I've had no problems at all. Mm-hmm. And interestingly, I've had a couple of colleagues that are kind of on a similar career path in mine that kind of took my advice to drop their insurance carriers, and they've all been successful also. Mm-hmm. Like, I have yet to hear of someone who didn't succeed at doing that. Now, the people that I'm talking about are really, really high quality physicians who have demand and they're doing something really, I mean, what everyone says is important, but like, they have a real narrow niche. It would be hard. Like, if you don't take insurance, you better provide something that other doctors don't provide. Either you provide a very specific expertise that other people don't have, or you provide a level of service that other people don't provide. And so some, like, primary care practices that are concierge practices, provide a higher level of service. And that's what they in turn are charging their patients for. Hopefully they're good doctors also. But like, patients can call me on the phone, I'll call them back. There's very little barrier between patients and myself. And I have a lot of time. Like, I don't have to be running on the treadmill all the time. So I can call patients before surgery and say, hey, do you have any questions before tomorrow? I can call them after surgery. I can visit them in the hospital. I can even send them flowers if I want to, which I don't do all the time, but occasionally do for one reason or another. Someone has struggling with something, so maybe I'll do something to make them feel a little better. It's like, so my practice will send them some flowers. Why not? It's just nice. And it just starts to become a kind of, like, it starts to feel a little bit more like humanity. Like, a person's coming to me, not to the machine that is Dr. Fogelson in his practice, is coming to the person, Nick Fogelson, saying, can you help me? And I'm saying, well, let me see, maybe, let me talk to you about this problem and maybe we can help. And I don't sell my services as being that I'm the magic Wizard of Oz. Like, these people most of my patients have really difficult problems. And sometimes they fit into this category. I'm like, oh yeah, I definitely can help with that. Sometimes they fit in the category. I'm like, well, this is an interesting problem. Let me think about it. And then sometimes I come up with an idea. And then sometimes I go, you know what? I don't think I can help with this. I just talked to a patient on the phone that she had a neurosurgeon that has this really horrible neuropathic pain in her legs. And I'm pretty sure it was caused by her neurosurgery. And I'm like, yeah, I'm not a spinal surgeon. Like, I can't help with that. But I did give her a few resources. Like, well, I think that this would probably be best handled with a interventional pain management doctor doing a neurostimulator, because of what I know about the nerve. I've learned a lot about the nervous system in my studies. And I think about the pain she called me about. And I said, well, I can't help with this, but here's a path that will probably be the best. Did I charge her for my advice? No, she just called me on the phone and I talked to her. And I'm happy with that. Like, I'm like, if I helped her, then great. If I provided some little help, then good. How many doctors take free phone calls from random people that asking for your help without like making an appointment?
The questions that I had, you mentioned that a lot about time constraints and not being able to have the time to be able to spend with the patients, but also to cover the time that you spent exploring and reading and researching and things like that. that. So now that you have left academic medicine and you are now doing private practice, how do you bundle like the fees for all that extra research and studying that you do into the cost of your services, or how do you go about that?
Yeah. Not like an attorney. It's not like billable hours. Yeah. I mean, we just set fees on what we do. I mean, like my office fees are just sort of ordinary office fees. There's nothing particularly high. My surgical fees are definitely higher than what most insurance companies would pay. But I don't charge a patient for researching their case or thinking about it. My attorney does that to me, I think. But no, I don't do that. But I generally think of like any time and to some extent any money spent to improve myself as a physician is time and money well spent. And like if I do research to help one patient, it's going to help another patient.
That's right.
And if I spend $3,000 to get a pelvic cadaver once every 6 months and go do a dissection at the laparoscopy lab and buy the cadaver, like that's money well spent. Mm-hmm. Most people wouldn't do that. Most people would say, well, I don't have any more CME money. I don't want to do that. I'm like, well, actually, I can convert my expertise into money at any time. I know that because I decide to set my prices, the better of a physician I get, the more demand there will be for my services. And the thing is that does have a certain ethical responsibility to charge reasonable prices. I actually have competitors, colleagues / competitors kind of in this space who charge 3 times what I do. And I don't think they're any better I don't think they're any better than I am. They maybe not even as good. I don't know. But they just choose to. And it's like when you deal with the market of patients who are desperate, you have an ethical responsibility to not fleece them. It is reasonable to charge someone a $5,000 for surgery. Like that may be they choose to have a surgery rather than taking a vacation to Hawaii. Like that is okay. It is not reasonable to make them mortgage their home to have surgery. Mm-hmm. Like, in my opinion. Mm-hmm. Everyone has different opinions about the like that comes all down to the concepts of capitalism and the concepts of socialism and all kinds of things, and justice and so forth. Now, I will say that like I really want to help my patients. If I have a patient that needs to pay reduced fees, we will often do that or develop a payment plan or reduce things or whatever. And like in my life, I've never sent a patient to collections. I think collections agencies are evil and it's just not worth it. Like, why would you let some dog that's going to send some sort of ravenous dog chasing after someone's wallet? It's just insane. It's like, move on, help the next person. Again, that's the impersonalization of medicine that would say that I'm going to think of you as a debt, that I'm going to send some machine after you, who soulless machine that's going to do horrible things to try to collect $1,200 or whatever the hell it is. Mm-hmm. So I would never do that. And at the same time, like I had a patient, when you don't contract with insurance, you can do all kinds of creative things. I have a patient who's a commercial fisher person in Alaska, and she doesn't have any insurance because a lot of times these people that are kind of do seasonal work, they don't have health insurance. Mm-hmm. And she needed a surgery. I thought I really could help her. Very high probability I'd be able to help her. And we arranged to do her surgery at an outpatient surgery center where I have a reduced cash rate, where it's the facility fees are not super high. And then my surgery, she paid about half the fees in cash, and she paid the other half in fish. Oh. And wow. And I'm serious. Like she is an expert in fish. I am an expert in surgery. Mm-hmm. Like, let's trade our expertise. Like, I like fish, mm-hmm. you know.
It's like the fire system.
And I gave her top dollar for her fish. Like her fish, it's excellent. It was like right out of the ocean in Alaska and frozen on the boat. If I were to get that at Whole Foods, it would have been like $30 a pound. It's like really, really nice fish. And so I gave her top dollar for her fish. And I have enough fish in my freezer that probably my family will be able to eat delicious fish for a couple of years. And I guess it depends how often we want to eat fish. But the point is, like, I feel better about that than I would about the couple $1,000s or whatever it was. And she feels good about it too. In that, like, it's not even about the money. Like, it's the humanity of it. It's the value. It's like, she feels good about that. And she was shocked when I said, hey, why don't you pay for half your fees in fish? Like, you have a lot of fish, right? And she's like, really? I'm like, yeah, because like, I love fish. You're going to have great fish. It's going to be great. And I'll feel good about it. You'll feel good about it. My wife and family will like it.
Mm-hmm.
And would I take that money and buy the fish if it were my money? No, of course not. I mean, I might buy a little bit, but I'm not going to buy like freezer full of fish.
Mm-hmm.
But it's just like, I don't know, it's the barter system, right?
Mm-hmm.
So it has a certain value to it. It's not just financial. It has this humanity to it that you can't do in private. You can't do if you take insurance. Like, you're contractually bound that if you charge one insurance company fish, you're going to have to charge all the insurance companies in fish. I'm kind of joking, but
I follow.
But the point is that there's all kinds of legality. Like, you got to treat everybody the same.
Yeah.
So there's just is this different, like, when you decide to free yourself from the bonds of being contracted with all the insurance companies, it opens up a lot of flexibility, and you stop feeling like you're some slave to the system. Like, I felt like when you're trying to do complicated work and they're not paying you, they're sort of saying you can only get paid what we say you can get paid. And I'm like, what is that? I mean, it's almost like a indentured servitude of sorts. And I think a lot of physicians are fundamentally altruistic, and I'm very altruistic, but I do feel like the systematic, the industrialization of medicine kind of predates on the altruism of physicians. Because anytime a physician complains about their work life, about anything, a lot of times it comes down to, like, you're privileged to be a doctor. You should be very, I don't know, like every part of the medical system is all about making money.
Mm-hmm.
And then they ask the physicians to be incredibly altruistic and not to care about their quality of life, not to care about what they're paid. And it's bullshit. It's bullshit because it's kind of abusive, to be honest.
And the truth of the matter is that physicians are being harmed by this, right? And you think about the mental health of physicians, and we think about suicide amongst physicians, and how 300 to 400 of physicians die every year due to suicide.
I know. And it's, and I think that unfortunately people come to think they hate being a doctor. I'm like, no, I don't think you do. Like, you went to medical school for a reason. Like, there are some people that were ill-suited for medical school, but mostly people hate, like, the system has driven the joy of medicine out of them because it's just not allowing them to enjoy it. And I mean, what I've chosen is not for everyone. I mean, I think it would be much more difficult to do what I do if I were a general GP or something, but not impossible. I mean, again, I think that you just have to provide something that patients it may not be that you know how to fix some rare disease. It's just that maybe you're available on the phone, or maybe I don't know, that's what concierge practice is. And then even this sort of predating on the altruism of physicians, they'll try to give a guilt trip to someone like me, or, which I don't even accept, but people would try, or to someone who's chosen a concierge practice and say, oh my gosh, you're just taking care of rich people. You're just out for yourself, blah, 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 blah. And I'm like, it's a bunch of nonsense. Like, no, you're just deciding to value yourself. You're deciding to say that the system is not valuing me in the way that I value myself, and I don't want to participate anymore. And you can continue to provide care for people that can't afford your normal rates. When you don't take insurance, you can do whatever you want. You can work for fish, you can work for chickens, you can work for $5, you can do whatever you choose. And what, I mean, it's almost the opposite. When I was in academia, like, one of the things that made me quit, I'll tell you a funny story, is that I had a patient that had the largest fibroid uterus I'd ever seen. It was like she was full-term triplets with her huge, huge abdomen, a young, middle-aged African-American woman, low socioeconomic situation. She worked as a daycare attendant at a fancy athletic club. So rich people who went to this club drop off their kids with her and go work out. And that was her life. She came into the clinic at Grady, which is the public hospital where I was working. And she had this just unbelievable, largest fibroid uterus I've ever seen in my life. And I'm like, oh my God, like, she's saying I have pain. I'm like, of course you have pain. You're walking around with like 30 pounds of tumor in your belly. And I said, please let us do a hysterectomy. We can fix this. And she says, you know what? They've been saying that for years, but I can't afford to they say it'll take 4 to 6 weeks off of work. Like, I can't afford it. I'll get kicked out of my apartment. Like, she lives paycheck to paycheck, and she lives in a shitty tenement or something where the landlord is going to kick her out the instant she doesn't pay rent. And I felt terrible. And at that point, I had developed a pretty significant presence on social media through a variety of things that I did that I always enjoyed, that also the institution didn't like, which was crazy, but they didn't like that. And I said, oh, this is bullshit. And I asked her a question. I said, how much money would you need for us to do this surgery and you to support yourself while you're recovering? There's got to be a number. And she says, I don't know, like $2,000. I said, okay, book the surgery. I'll get you $2,000.
Wow.
And I went online and I told her story. I took a picture of her in my Emory jacket, which was maybe stupid. And I made a little video. I went online. I broadcast to like the 10,000 people that follow my Facebook profile. And I say, would anybody like to give $5 to this woman, or $10 or whatever? I raised like, I don't know, $3,500 in 20 minutes or 2 hours, or I don't know, whatever it was. It was less than 24 hours. I got the cash. I put it in her hands. I booked her surgery, gave her the money, and I almost got fired for it. And I was called before the chair. The chair was actually out of town, so I got called before the vice chair, which was kind of bad because the chair and I were good, much better relationship than I had with the vice chair. I mean, I didn't have a bad relationship with the vice chair, but I didn't have any relationship with her really. And basically I was forced to bare my throat or get fired. And I was told that I had broken rules about fundraising. I was told that I was breaking insurance laws because I was going to treat one patient differently than I treated another. I was told that all kinds of just horseshit. And maybe in the legality of all of it, maybe they were right. But if I had asked, can I do this? Of course they would have said no. I mean, what's the chance they would have said yes? 0% chance. And I felt like, wait, there's this woman with this horrible problem and I can fix her problem. I have the power to fix it. And I guarantee I can raise this money. So I just raised it and I fixed it. And we posted her surgery too. And I was so pissed off that they were angry because I was so happy about it. I was like, this is one of the best things I've ever done as a physician. I felt great about it. I was like, you know what? I really did something good here. And they were telling me I did something bad. And even to this day, I don't think the chair realizes what he lost by firing me. I mean, they didn't fire me, but I left. And maybe they don't even know this. Like, this is why I left. Like, well, it was the straw that broke the camel's back, I guess you would say. Mm-hmm. But they would have fired me. Like, if it wasn't for the fact that I basically laid down with my throat bare and said, oh, I'm sorry, that they would have fired me. And part of me said, like, man, you could have a fantastic story in the news about a physician who did this great thing for a patient, and it could be a wonderful piece of positive press for Emory University. Or you could have a story about wrongful termination lawsuit for firing a doctor for raising money for his patient. Like, which one would you want? And there was a part of me that said, go, fire me. This is going to be awesome. I'm going to sue you to death. But I just forget it. I just quit. And so I didn't quit for about 6 months, but like that was the end. And it was so short-sighted of an institution to have a person who's willing to creatively do something for their patient, to see that as a threat and see it as like, oh my gosh, this is the head that's sticking up that we need to hammer down. And I was like, oh. And so like, it's an interesting thing that like, that's what organized medicine wants to do. If you're the doctor with your head up, they just want to put you down here and make sure everyone's like this. And so not interesting to me anymore. And so that was probably the interesting story in all this.
Wow. That's so unfortunate. That was the response. And the patient was fine with this, right? Like it wasn't like the patient didn't want her picture taken or had any complaints.
Oh, of course. No, she was over the moon that I wanted to help her. She was touched. She was crying. She was happy. If I had made this video without my Emory jacket on, maybe that would have been better. they were pissed that I was sort of like representing myself as a representation of Emory and not just as myself.
Mm-hmm.
Yeah, maybe I could have made the video without my jacket on. Would that have mattered? Probably not. But I guess that was the thing that bothered them the most. And it was like, I don't know. It seems like that's a pretty good thing for your institution to me, but whatever. And so you can't fight against it. You either got to get on the bus and go where that institution wants to go or not. Like, you can't live your life fighting against it. It's just brutal. And so if you're not aligned with what they want to do, then you better just get out, because you're not going to change it. Like, these big institutions are too big. And if you want to wait until you're the chair and you think you're going to change it when you're the chair, you won't. Like, there's still going to be inertia that you won't have the power to fix. There was a time where I thought, well, eventually I'll become the chair of this department or something, or a department, and I'll do it my way. But even that's kind of A, that's a long time to wait. But B, that also is probably naive. Like, the inertias and the pressures on you will still demand things of you that you won't like. So,
one last question or recommendation is, do you have any pearls of wisdom to my audience that you would like to leave?
Everyone should have a therapist, including residents. I think that every residency program should have mandatory psychotherapy once a month for all residents. Nobody knows. I'll say this to the residents: you have no idea who you are yet. You spent your entire life being this proto-doctor. And now that you are a doctor for the first time, you still have no idea who you are, because your entire life has been doctorhood. And the biggest challenge that people experience, I believe, in medical training is sort of the moment where they go like, well, who the hell am I when I'm not a doctor? Or once they come out from the difficulties of medical training and actually have a little bit of time to experience their own life, like, what I want to be other than. And I think that a lot of the unhappiness of residency and training could be better if people had a professional level outlet to figure that out. So that would be a piece of advice. The other piece of advice is just, if you love being a doctor, figure out how to be a doctor in the way that you want to do it. Society will value you. Like, society respects and values doctors. You just have to, like, if you're really passionate about it, that will show through. If you want to just be a doctor as a job and have it just not really be your core identity, then that's fine. Then probably you don't want to do that. And there's nothing wrong with that. That's fine. But that you actually can choose to do it differently than other people tell you to do it. And what you have to provide is of value, and people will pay you to do it. And if 100 people tell you that you can't do it, that's just because they're too afraid to try, or they're envious of your even attempt at doing that. And what's the worst that happens? Like, if you decide to try a non-standard practice in medicine, there's always a job for you. It's not like you're going to go and do that. You're jumping off a cliff into spikes. You just find out that, hey, it didn't work. You go get a job. So it's like taking birth control pills for your pelvic pain. Like, it might work, it might not. But once you stop taking it, it's out and you're back where you started. It's like, if you want to try a non-standard way of practicing medicine, if you want to go for Doctors Without Borders, you want to go and do whatever, like, your doctorhood is your own. It's your own superpower. And don't let the system teach you that you're owned by them, because you're not. And the medical system can't do what you do. They just turn what you do into, they kind of teaching you that you are like a spigot of medicine, and they're going to trade your water for money, but they're going to handle all the business. Like, as long as you're willing to get a little bit involved in the business of medicine, which is, to me at least, kind of fascinating, you can do whatever you want. And if it doesn't work out, you can always get a job. Or if you're happy with what you're doing, great. But don't be afraid to change if you're not. If anybody is compelled to contact me to discuss further, feel free. I'm on Facebook. My professional profile is Nicholas Fogelson, physician. The other one's my personal profile. I probably won't answer you that on that one, but the physician one, I will answer you if you DM me. And my website's endometriosis.com if anybody's interested. And keep listening to this podcast. It's cool. Cool.
Yeah. Who says a doc can't rap? DOCTORJB, the greatest doctor to ever touch the mic, the greatest podcast ever broadcasted or pre-recorded. Come learn some. Each one teach one. I'm done.